Good morning, everyone. Thank you so much for joining us for one of our morning breakout sessions. It's great to see all of you. My name is Tatiana. I'm a Senior Data Analyst in the Improvement Analytics Unit at the Health Foundation, and I'll be your chair for today. So we've got 5 fantastic speakers today to talk to us about research and evaluation working collaboratively across organizations. So this session has, as you can see, 5 speakers. So they'll each be speaking to you for 5 to 7 minutes, and then you'll have about 20 minutes at the end for Q&A. Please, if you haven't already, make sure to put your phones on silent and do use our hashtag rapid evaluation to keep the conversation going. And I'll just be introducing each of the speakers in turn as they come up to the podium. So without further ado, first we've got Chris, who's a senior fellow at the Nuffield Trust and member of the NIHR Rapid Evaluation Team, RESET, and he'll be talking to us today about how do we liaise with local teams, experiences from rapid quantitative evaluations. Thank you, Chris.
Great, thank you. Great, thank you, Tatiana. Thank you, everybody. So this is really going to be building, so I'm just talking from some experiences that we've had with RESET on liaising with why it's important in some respects to be liaising with local teams. And although RESET evaluations are all mixed methods, there's a difference in the way that liaison is likely to be working between the sort of the quantitative sides and qualitative sides. And I'm very much speaking from the quantitative aspect, although there may be some learning from qualitative engagement as well that might come from this. I'm going to come and describe why it's important, provide some examples, and then finally raise some questions, which certainly I have about where things can go further forward. And I think some of these have been already touched on this morning as well by the discussions there. So moving on to what is probably a classic evaluation relationship, where the evaluation team basically will bring in the data that's required. There may be sort of data sharing agreements with local teams who may be providing data for the evaluation. There may be data coming from other sources. But then all the analysis is contained within the evaluation team, and then after that they make recommendations for policy or impact, or give some evaluation of actually what the impact of the innovations actually are. And there may be some further engagement with local teams afterwards, but based on disseminating findings and making some recommendations which might lead to sort of further evaluation in the future. This might not always work in a rapid evaluation. I think some of these have already been talked about today, and they're quite well rehearsed. Innovations, of course, some of them are very recently introduced, and so the data collection might only have just started. The implementation of the innovations might not have been well embedded yet, and they may be trying things out and they're making some changes. So what you're actually collecting data on isn't actually a stable process. Some outcomes, particularly when you're thinking of things like long-term clinical outcomes, may be only measurable in the longer term and beyond the time frame of the evaluation itself. This is this question that came up in the last session about how we make use of what's there or what we should be making use of, and sometimes the data that's available isn't actually necessarily the right data that you need to be using to evaluate all the relevant aspects. And finally, there's a practical point about actually acquiring some of the better sort of data on person level data and all the IG issues that need to go through and the ethics applications to be able to get hold of some of this information. May not be enough time in the evaluation to be actually able to do that. So let's start with just give you a couple of examples of how these relationships with local teams have worked in some recent RESET evaluations. The first one is looking at evaluation of patient-initiated follow-ups, which are outpatient appointments where the patient will actually make their own decision as to when they want to. They have a phone number for the hospital and the outpatient department in the hospital, and when they need to see somebody, they will make an appointment. They will instigate the appointment by ringing up the department, rather than having a sort of a routine 5 or 6 monthly, 6 or 12 monthly cycle. The idea is here that it seemed to avoid some unnecessary follow-up appointments that do take place, and also make sure that patients, when they do need to be seen, are being seen in a timely fashion. So for this, we had access to person-level data on hospital records, but we never had information on who was actually on PIFU pathways. Wasn't available. It was becoming available, and they were starting to record it in the hospital PAS systems, but it wasn't yet at a stage where we could use it. So we knew that when we were evaluating this, that there would be better ways of evaluating this just coming around the corner. Not only that, but the way that PIFU is being implemented in local areas, different specialties, even different within trusts, and the same specialties, but in different trusts, is all very, very different types of implementation. So if you're trying to look at this from a national level, you don't really get the nuances that you've got within the different ways it's being implemented. You're not answering the question as to what are the best ways of implementing PIFU. So in a lot of ways, this means that there's a responsibility really for the local teams to be trying to work this out for themselves and having some guidance that will enable them to do this. So we developed an evaluation guide. This is going back to obviously goes into discussion about toolkits that was mentioned in the last session, and engaged with the local teams to try and help them to bring this up. And we're also working closely with NHS England, who are able to propagate some of these guides as well. The second example is looking at peer-supported social care in prisons. This is a very different sort of environment. The idea here is that for non-personal people prisoners with social care needs, some of their non-personal care is taken up by other prisoners, basically, who will volunteer to do this. Some are often paid to do that. And the question here is about, how effective are these schemes, and are there types of schemes that work better than others? There is actually very little data here at all that we could actually use for quantitatively. It was very much a qualitative study, this, but we were able to, we wanted to make some recommendations as to how to take this forward, how to evaluate this quantitatively in future. But we understood there is not just lack of data, there's just uncertainty as to what relevant outcomes are, what does good actually look like for these types of schemes. And not just that, within this is very, we talked about capacity in the health sector. In the prison sector, the capacity for analysis and local analysis is very, very, very limited indeed. In fact, if you just recommend collecting some more data, that would, again, it's very, very, there's very doubts as to whether that's even possible. So, during this evaluation, we picked up from local teams about the information on their data capabilities. But we then decided, we then created we had a system for then thinking, what are the relevant outcome measures for this, through engagement with stakeholders, PPIE, etc. And again, developed some sort of evaluation guide that could be taken up, not just really taken up by the local teams, but for them to then, it might need to lead to them asking for external evaluation teams, research teams, to then be able to do that further evaluation for them. So just quick conclusions then. We are here, at the moment we're at the stage of providing evaluation guides, tools, toolkits that can be picked up by local teams, but I think, as been mentioned before, there's really some reliance here, degree of reliance on hope and expectation that these things will be taken up. So the question for us really is, what strategies will maximise the chances of take-up? When should we be starting to work with local analytical teams? Should that happen from day one? And if so, what does it actually look like? And what do we do if local capacity or capability is limited? And that, we talked about the prison sector there, but it is increasingly a situation in the health sector and across social care as well. So some questions there for bringing up later, and I shall now pass on to the next speaker.
So thanks for the chance to talk to you today about something that's dear to my heart. So I'm one of the partners in a wider academic partnership led by Professor Karen Spilsbury in the UK. Formerly Jan Hamers in Holland, but now Hilde Verbeek, who's taken over the chair of the Dutch version of what we call Niche Leads. And we're part of the International Living Lab movement, which I shall tell you all about today. So I've got a slide on structure, but actually structure is always traditionally the least interesting part of any collaboration. So I want to focus first on what drives us and what we're about. So we're an academic partnership, so it's University of Leeds, Leeds Beckett University, and a social care economy of some 1.5 million people in the sort of Leeds city region. Specifically, we work with two independent providers, medium-sized independent providers, 6 or 7, so Springfield Healthcare, Westwood Healthcare, and HC1, a large corporate provider as well. And there are our care home partners in this. And we work with what is it's always tempting to talk we heard about mega rapid evaluations, ultra rapid, kind of sexy things, rapid, ooh, right? Actually, we're not about that. What we're about is a self-evident truth, which is research, care home provision, quality, it's all relational. It all depends on relationships. Everything stems from relationships. Trying to do research in what Sean called the swampy lowlands of real-world social care, is impossible if you can't build relationships. So the partnership is all about relationships and a strong, firm, unwavering focus on a couple of things, 3 things. A focus on residents, people who live in care homes and domiciliary care to a lesser extent in terms of frequency of work, but care homes specifically. Quality is really important to us. Quality of care, how people experience homes and how it's delivered. Quality of life, which I know Anne-Marie's got views on and lots of expertise in, but also crucially quality of work, because this is not healthcare, so there's no penicillin, there's no kind of hip fractures. Well, ironically, there are lots of hip fractures, but there's no fix for hip fractures readily available in the care home sector. It's all about the caring workforce. They generate, when people experience it well, it's a caring workforce, and by God, when it goes wrong, it's a caring workforce. So it's all about the workforce. So we've got an unwavering commitment to that. But also, when we say interdisciplinary, quite often today, if I challenge people interdisciplinary, they'll say we've got a data scientist, a qualitative scientist, we've got maybe a chief exec who goes to a few units. For us, our interdisciplinarity, we have got data scientists, we have got social scientists, we've got health services researchers and clinicians, but we've also got geriatricians, we've got dentists, we've got public health specialists, all of us, as well as the care sector and relationships, the wealth of expertise that exists in the social care sector working with us. So it's a genuine partnership. Our model, it's not ultra rapid, it's not mega rapid, it's not, masses of routine data. It's a really simple one, but done well. So our model involves listening. So these are kind of words that just flow off the tongue. We listen, right? Warm, everyone feels nice. But when we say listen, what we really mean is we spend time systematically gathering the uncertainties of the care sector. So before the pandemic, we undertook and published a big survey of uncertainties experienced by managers and care staff and residents and families, and we prioritised those studies in the SearchU study. During the pandemic, we did it again, but this time in a pandemic context. It was different. Life was different. It may never be the same again, but we did it again. And now we've been working with the NIHR's Enrich Care Home Support Network to do this nationally. And I think we've got a sort of database of about 600 uncertainties that really, really matter to the sector. And that's our target. That's what we work with. Now, a lot of them are not things which are amenable to research. We've heard about magical thinking earlier on. So we're not engaged in magical thinking. We can't pretend that we've got magic bullets that can fix stuff. But what we do is we absolutely use those real-world uncertainties and those prioritised uncertainties as the basis for the second thing, which is really high-quality research. So along the way, we do things quickly and we get some quick wins. So, for example, if we get funding for a large study developing a complex intervention around oral care, the COMMIT study, which is one of the things we did, That stems from a single carer asking one of our staff, one of our partners, what do I do about oral care for people with dementia that resist oral care? Right? It's horrible if your mum or your auntie or your grandma has got rotting teeth in a care home and no one's caring for them. It's a horrible experience, and there are things that we can do even if people don't want them to be done. So we synthesize knowledge rapidly, we instigate training as part of our intervention, we secure external funding to do the kind of high quality development work, scientific development work, to produce high quality generalizable research. But along the way, there are wins for the sector, high-quality training. Whether it works or not, it's stuff they weren't getting before for free. High-quality evidence synthesis, which gives clear guidance. Again, stuff that didn't exist before. So even if the evaluation 3-4 years down the line shows, well, it's of limited effect, we've still got some wins. So unashamedly, not about improvement, unashamedly not about quality improvement, we are all about high quality scientific research evidence. And crucially, it needs to be sustainable, so we've got to focus on implementation science, so that actually, as I said at the beginning, there's a scientific element, but it's tailored, it's fitted into this truth, which is it's relational. So for all of the implementation science models, the knowledge to action frameworks, the CFIR kind of frameworks that I use, the truth is, most of our business is done face-to-face with the staff, and that's what's really important. So I said about structure, and normally people switch off and go, oh God, this is so boring. But ultimately, I want you to focus on the green thing here, which is this key role which unites the Dutch experience of a living labs model. So they've got a 25-year history of sustained partnership, starting with a single provider. I think they've got 30 or 40 care providers and a local government province working with them. And the thing that makes that happen is this idea of linking pins, which is literally a Dutch translation from a Dutch. So linking pins sounds a bit weird, but it's, if I tell you what it is, you'll see why it's not so weird. So we have a scientific linking pin. So that's researchers, scientists who spend at least a day a week with a dedicated provider, building up those relationships, getting to know the people, getting to know the data, getting to know the possibilities and the feasibility, and then bringing that back to the partnership. Crucially, we have practice linking pins, who are people, carers, managers from a variety of backgrounds in the organisation, who are supported by the organisation. There's an investment, there's a buy-in, a commitment to allow them to spend time in another environment, a scientific environment, skilling up, getting the time and space and support to convert their uncertainties into questions, and to be part of research teams, which then, with our expertise and our track record, get the external funding required to do the high-quality science. And suddenly what was a carer in a care home is now a co-applicant on a bid and is doing a master's course for a career development fellowship and is on her way to undertaking a PhD at some point in the next future, where she started as a junior carer, and Irene is one of those people. So these practice linking pins are key. So this idea of spending time, embedded time, building relationships is really important. So what does partnership success look like for us? What is it that we hope to get out of this, and what do we get out of it? Equal opportunity. So we've got a pipeline now that involves everyone from families and friends of people who live in homes and residents themselves being part of projects, but also career development. So from undergraduates who've never been in a care home, undergraduate scientists who've never been in a care home, or clinicians, suddenly they're planning and doing research with homes as part of their undergraduate training and getting exposed to social care and plugging a workforce gap. And we've got consultant geriatricians working with us to look at things like falls prediction with homes to make sure that ultimately the products of their high quality fellowships have relevance for homes, rapidity and rigour that Judith mentioned earlier on. Mutual gain, we get out of this, what do we get? We get sensible questions and a more feasible research environment to do the kind of science that we need to do. And all of the kudos that goes with publications, all that stuff. However, the homes also get, the providers also get a skilled up workforce, managers who can suddenly read spreadsheets better, managers who are more confident who are more confident tackling the regulator on issues of safety and efficacy based on data and projects that we've worked with them on that. And they get bespoke advice as well, because we've got a relationship with them. So they ask us questions about how to increase the number of men in the workforce. What's the relationship between staffing and quality? What does it mean for us? And we can help them with that. But they also get PR. They sell their involvement as part of their commercial proposition to the people who pay for their care and the families who pay for their care. It's a badge of honour for the care homes to be doing this. There's value in it, real value, as in they get fees. People are more attracted to homes where good stuff happens and is seen to happen and the conditions are in place. I've talked about niche know-how and training and embedding evidence-based solutions. Some of our research will take 2, 3, 4 years to develop, but along the way there are evidence-based solutions which we have to do in our grant development work and our implementation, which translate into products that homes can use, and they're evidence-based, more evidence-based than the stuff they were using in the past. Impact of enhanced quality of care. We talked about disadoption. One of the things about social care is it's a market that's ripe for targeting by technology companies, the magical thinking that Thea was saying earlier on. And they promise them all sorts of shiny beads. But as one CEO of a tech company said to me, who works in social care, says, we only have to sell them to lots of care homes once to make a lot of money. We don't have to have a relationship. It doesn't have to work. We just need to sell it once. And they can sell lots of things once. So we spend a lot of time debunking, saying, you wanted to hear A, but actually it's A and B. And the B is really important. Don't spend your money. Save it. Do it on something else. So that's really important. I wanted to talk about continuity as a final point, and value and impact. The financial bottom line for these providers is they support us financially. And when we talk to researchers, they think in terms of millions. We're talking just tens of thousands. So we take about £100,000 a year from free providers as their financial commitment. And we've leveraged that £100,000 a year to a kind of portfolio now of about £8 million worth of funded R&D. And it's provided a funded platform for us to bring the care home sector into the National School for Social Care and the big NIHR infrastructure, which in turn allows us to scale up our ideas, spread the message a bit wider, and also do more of a kind of national scientific work based on the local problems. So it's been, there's real value in the partnership, and by value I mean financial value. So we're just about to enter our next 5 years. We've just celebrated our 5-year anniversary, not 25 like in the Dutch model, and we're part of an international network of Austria, Germany, Spain, Brazil, I think Canada as well now. And we're just about to enter the next 5-year phase. So we're very excited by it. We've got loads of possibilities working with Anne-Marie and others. And if you're interested in what we do and what things, we get the slides, there's some hyperlinks in there, and just talk to me around the day, and I'd be more than happy to do that. So thank you.
Hi everyone, I'm here flying the flag for social care. So I'm just going to give you a little overview. So what I'm talking about today is the learning from 6 NIHR-funded social care research partnerships, which were funded 3 years ago now. Some of them are coming to the end this year. Some of them have got another year or so left. The initiative behind these 6 partnerships was NIHR recognising that there was a need to build research capacity. So a lot of the things that you've been hearing about this morning wouldn't necessarily be possible or workable in social care settings because the infrastructure, the support, the know-how and the readiness for research just isn't there within the social care infrastructures. And so this is what these 6 partnerships aim to address. And I'm going to talk about the one in red, the Kent Research Partnership, but I just wanted to make you aware of the other ones that are happening around the country. And some of what I talk about today is because I also lead the National Cross Partnership Group, which is where we're trying to learn from each other, which is partnership, on steroids. So the Kent Research Partnership in particular As I said, it's social care focused. Our partners are Kent County Council, Adult Social Care Team, but also a number of national and local provider representative organisations, such as the National Care Forum, the Home Care Association, Skills for Care, and then more locally, Kent Integrated Care Alliance, which represents social care providers across the county. We also have an amazing engaged working group of people with lived experience of social care, and that was a real key fundamental part of the partnership working that we were doing to make sure that people living in Kent and using social care and support and their family carers were influencing everything we do, from research priority setting all the way through to governance and evaluating the impact of the partnership. As part of our work, we developed 2 communities of practice, and this was based on the research priority setting exercise that we did in the first 6 to 9 months. And the first one is around complex needs throughout the lifespan, so it's not about curing people's needs in social care, it's about how do we support people to live a life of quality and maintain that quality as their needs progress, which is the truth for most people receiving long-term care, particularly older people. And the other one is around supporting and sustaining the social care workforce. When we started this partnership, we expected to have maybe a community of practice around care homes or a community of practice around domiciliary care. So we were quite interested in the fact that these were the communities of practice that came out as being important to local stakeholders, particularly those with lived experience who recognised that without a good workforce, there was no change was going to happen in terms of quality of care or outcomes for people drawing on care and support. So, I think probably of interest to you all today is the learning that we've had from the 6 partnerships around what makes partnership working work and what the pitfalls are. And as I say, these are reflected in our own experiences at the Kent Research Partnership, but also from the other 5 social care partnerships. And just going to name check my colleague, Dr. Jolie Keemink, who produced this slide for me. She's a researcher working on the cross-partnership group. And these top tips came from interviews with all the different stakeholders in the different partnerships. So the first one is time. We're here today at a rapid evaluation conference, and I'm going to tell you that partnership working takes a lot of time. It really is not rapid. There's nothing rapid about it. And I think whatever you estimate the time that you're going to need, maybe double it, and that will be more realistic. The second top tip that came from these interviews was around expectation management. So I think it's really clear, and we'll all know this from working with partners on projects, actually making sure that you've got a common understanding and that you're talking the same language and your expectations of the partnership working are the same is critical. And these are the sorts of things that can be easily lost in translation when you're setting partnerships up. We use sometimes the same language, but we mean different things, or we understand different things from that language. Relationships, as Carl said, is absolutely key. And we thought that we'd done that really well, but what we found across the 6 partnerships is that people formed relationships at different levels within the organisations that we were working with. And there are some pitfalls with this, and what you've actually got to do is make sure that you're hitting every layer of those partner organisations. For example, we were probably coming in around mid-level management, so, principal social workers, managers, and provider representatives. But it took a while for us to get buy-in at that executive level. So they were keen on the funding going through. They supported it. They signed off the bids, the application process. But actually there were some barriers in terms of culture change within those organisations that we couldn't address without getting buy-in and having relationships with people sitting at the top table in that executive group. Sounds obvious, but these are the things that sometimes you have to learn the hard way. So thinking about perspectives, so our perspective as researchers is often to drive forward. This is what we said we were going to do in our aims and objectives. This is our timeline that we've committed to with the funder, and let's keep the project on track. Recognising that in social care, and I'm sure this is absolutely relevant in healthcare as well, frontline practitioners, care provider organisation, clinicians have different priorities, and these partnerships were set up during COVID. And that really gave us food for thought about where their priorities were. And it wasn't on this particular research project. And it's recognising that and understanding that. And then that links to the next point, which is around being flexible. If you're going to work with frontline care providers and within those systems, you absolutely have to be flexible around how you your timelines, how you communicate, and maybe some of the ways that you disseminate and mobilise knowledge, which is going to be very different to how we're used to doing it conventional research. Thinking about the infrastructure, we built in from the start funding for our partners. We didn't expect anybody to be contributing to this partnership for free. Nonetheless, what was really interesting was that the partners that we worked with didn't always have systems to make the best use of that funding. So their infrastructure didn't allow for example, practitioners to be bought out and have dedicated protected time for research. And that's been a really interesting learning process. And part of our capacity building has been helping them to get their heads around how they might do that in the future, so that practitioners, such as social workers, occupational therapists, nurses working in care homes, care home managers, may be bought out of some of their full-time role, as clinical academics might be, so that they can participate, engage with and lead research. So this bigger question of involvement, we have an amazing working group of lived experience, and what we found is that they have been better and found it easier to be involved in the research than some of our frontline staff or workforce colleagues. So thinking about how do we involve people and the differences between involving people with lived experience, which maybe in social care we have a longer history of doing, versus how we involve frontline staff, which has been a steeper learning curve for us. Clear markers for success. As I alluded to earlier, some of our markers for success are probably around meeting the objectives that we set out in the bid, but that might be slightly different for some of our, or it has been slightly different for some of our partners. And a sense that small successes have to be celebrated, because sometimes we could sit back and think, I mean, one of our chair of our lived experience working group, who is a LACO applicant, never been involved in research before, I remember about a year into the partnership, he said, "What have you done? You've done nothing in this year." And to him, it's because it felt like we weren't changing the world. We hadn't changed anything for people who were receiving social care in Kent. And so there was that frustration. And we had to sit down and say, well, this is what we've done. Until this partnership, there were no communities of practice. There was no forum for people with lived experience, people working in frontline services and researchers to come together and talk about these issues. We didn't have any resources for embedded researchers similar to that LinkedIn model, and now we do. And that first year is about learning. It's about getting to know each other. It's about common language, but it's slow. And so how do you build those small markers of success in and then celebrate them so that people do feel that they're going on a journey with you and achieving something rather than feeling like they're wasting their time? So some of those learning points have been really interesting for us. This one's a bit of a boring one, but a really important one. The length of time it takes to do contracting. So, you know, this varied a lot across the 6 social care partnerships, I should say, nationally, and it depended on how many local authorities they were working with. They were also contracting to care provider organisations, third parties, you know, voluntary sector organisations. These things take time, and they can in themselves be barriers to partnership working. So how can we streamline those? And the onus is not only on the higher education, but also on the funder and the sector as a whole to be thinking about, do we need to have contracts for every activity? How can we streamline these processes and make things progress more rapidly? And finally, longevity. This is something we're starting to think about 3 years into a 4-year partnership. When this funding ends, what happens to all the work that we've done? How do we move now to something that's sustainable and workable? And it may be that we need to be thinking about models like niche, and what can the sector do to support some of these mechanisms, some of these roles that we've built in have been funded by NIHR, to make sure that the learning from this partnership and the infrastructure that we've put in place isn't lost when the project itself finishes. Okay, and that's just to show you the usual disclaimer. And anyone who's interested in finding more about the partnership or our work, we have a website, we have a YouTube channel, so do take a look. Thank you.
Hi, so my name is Charlotte. I'm a consultant in public health, and I'm also the programme director for the very newly formed Islington HDRC site. So HDRCs are a new form of NIHR funding, and they are focused actually at local authorities. And it's come from an acknowledgement that actually a lot of the things that impact on health actually aren't run by the NHS. They're about the wider determinants of health, and the importance of looking at these and building research and understanding around needs is really, really important. And in order to do that, local authorities need to be supported. So I've worked across NHS and local authority, and one of the things that has struck me about working within a local authority is the approach to using evidence and evidence-informed decision-making is very different from how it was within the NHS. I think this is a really fantastic opportunity now to look at how we can embed both research and research capability across local authorities, but also what has been really fundamental to this is working in partnership. So locally within Islington, our HDRC site has been called Evidence Islington. I think that builds a little bit on some of the conversation earlier about language and the importance of language. So we've really tried to shift language from being around research to about being around evidence. And in terms of our approach, we were given a developmental year by NIHR, who then gave us full HDRC status in October. So as I say, we are new and we're building on our approach. But the aims of Evidence Islington is to really reduce inequalities and improve residents' health and well-being by creating organisations and culture where research, data and residents' insight are intrinsic to everything we do. So a lot of what I'm wanting to do with this programme is around that sustainability and how we really build this in as just standard practice really across the local authority. We have got 5 years of funding, and our programme has been divided into 3 core work streams. The first one is around strengthening collaboration and culture, and that's both an internal piece of work, so looking around how we work with officers, how we work with members to really get everybody to be thinking about evidence, but also thinking around how we work across the system. So 2 of our core partners are academic partners. We're partnered with London School of Hygiene and Tropical Medicine and UCL, and a lot of it is about how we work as a collaborative there, but also working with our residents and our VCS organisations. So another of our partners is Healthwatch Islington. The second work stream is around data and infrastructure, and this is about how we make access to high quality data readily available. So we know we've got quite a lot of data. What I don't think we're so good at is bringing that together to create the insights and also to make it easy to access both across the council but also with our partners. And then the third work stream is around capacity building. And this is really around creating a workforce which includes our residents who can be active participants and ambassadors for research. So how do we build both the competence and the confidence to take research forward and to become truly active within research? One thing I would say is central to our success in becoming a HDRC has been our partnership approach. And this isn't something that happened overnight. And when we were talking around rapid evaluation earlier, this has been different. This is very much a sort of slow burn in terms of the partnerships that we have created have really happened over a number of years. And I think this has been really beneficial when we put in our bid to become a HDRC, because we understood each of our different institutions. We understood what we could all bring to the table, but we also understood the challenges in terms of trying to do research across a local authority and how having this resource and this extra capacity could support us in this. So this just gives a bit of an example of that journey to collaboration, and this is about the work that we've done with, as a public health team within the council, with one of our partners, UCL. And this is a journey which is over 10 years in the making, really. So we started off very much an individual partnership. I had a good working relationship with one of the researchers, and we looked at how we could develop and explore this. So, for instance, she'd come in and do some teaching for our staff. I would go and teach at UCL, and looking at some of small projects where we could work on together. This developed over time into joint working across departments, looking at how, as I'm an educational supervisor, I have registrars from public health and general practice working with me. And part of our programme is how, as part of their placement with me, could they also spend time at a university. So creating a programme together, which then also resulted in us bidding for additional funding and looking at how we could provide opportunities for other people within the council to be seconded into the university and to have protected time to do research, and vice versa, with researchers coming and working with us within the council. And I think that really has created a very good foundation in terms of what we're now taking forward in terms of the Evidence Islington work. And I think as a good example here, the work we're doing with Evidence Islington and the capacity building is going to be a joint initiative between our HDRC resource and also ARC North Thames. So the collaboration hasn't only been between organisations in terms of HDRC, it's also around how we work effectively across the council. So definitely the nursery bed of our HDRC has been within public health, but what we're very keen to do is for this to be seen as part of our strategic priorities, that this is owned by the council, the local authority, not just public health. So a lot of our work since we were awarded HDRC in October has been thinking around how we infiltrate the rest of the council. So part of this has been creating our criteria for how we prioritise where we focus our time as a HDRC site. To support this, we've come up with specific criteria which we think will help us create a sustainable approach, which isn't just focused about research, but how can we make services better within our local authority area. So we've created these 6 core priorities in terms of identifying research, identifying how it links in with our local priorities, particularly thinking around the strategic plan. Really, really important to us is around how whatever we will do will be addressing inequalities within our residents. So identifying where the focus will be so that we're driving reductions in inequalities. Considering resident priorities, and here we're very keen that we don't replicate or duplicate work that's been done before, but how we bring a lot of the evidence we have and create insights from that to inform what we take forward. The importance of thinking around how it links in with external interest and relevance. So thinking around where we can work with our academic partners, where have they got particular interests, so that we can create partnerships from the outset. But also being clear that we are actually filling an evidence gap. So a lot of our initial work has been working with other officers across the council who have identified areas that they think could be improved, could be done differently. But what we've then done as an initial first step is rapid evidence reviews. So going and looking at the evidence to see what we can bring from elsewhere. And actually that's been a really quick win for us, because a lot of the issues that officers are coming to us with, actually the answers are out there. It's just potentially they don't have the time, the capacity or the skill set to bring that together in a way which answers the questions that they have locally. And then the final one is around scope of influence. So there are loads of things that as a council we want to change, but we can't change everything. And what we think is important in terms of the research we do is that we are picking topics or issues where we as a council can make a change that residents will see. As we've been applying those criteria and working with our colleagues across the council and with members, what we've also realised is there's a really importance around staff capacity. So links into some of what our earlier presenters were saying. We need to have that capacity elsewhere. We've got loads now of academic support to do this work. What we're struggling with more is the capacity of our frontline officers to work with us in terms of the research we want to do. And also honing down on specifics of the question and the issues that we're trying to answer. So trying not to do everything at once, but being quite specific around what it is we are trying to make a difference to. Then in terms of taking this forward, we're trying to get a mix of very specifics and also the breadth. So as an example, we're looking at some areas of policy work. How do we work with our chairs of scrutiny, which are members, to look at how they use evidence differently in their decision making, which will be around process. But we also want to do some in-depth work where we, as part of HDRC, will be funding embedded researchers to go and sit in specific departments to really work with them to kind of co-create what the research is, but also at the same time be creating a skill set within those parts of the organisation in order for them to do the research. So our initial areas of where embedded researchers will be going will be around housing and our greening the environment and climate adaptation. Sorry, I've lost my last slide. So as an example here, we've identified 3 projects within housing where we will be given a particular focus to, looking at damp and mould, and part of this is around looking at the evidence. So how can we better link NHS data with data we hold within a council? Now that obviously has good academic interest, but also more importantly from a policy perspective, it's going to help us focusing our repairs and maintenance work to households where the risks around damp and mould are particularly significant. The other area we're looking at is around damp and mould sensors. So again, these can be put in households relatively low cost, but can be really good early indicators of early signs of damp and mould. However, what we're finding is our residents are really resistant to having them. So part of our research work is going to be looking at understanding what the issues are from a resident's perspective and looking at how we communicate differently around the impacts of these, because we can see from a policy and cost effectiveness perspective that could make a real difference in terms of what we want to do. So I think for us in terms of that partnership work, it's around identifying the core academic issues that we want to work on, but really importantly for us is how do we then take that and make a difference in terms of policy and delivery for residents. Thank you.
Thank you. Lovely to see you all. Thank you so much. My name is Pavi. I'm Senior Policy Advisor at National Voices, and I've been leading on some of our work around clinical research lately. So apologies from Sharon for not being able to attend today, but I'll try my best to cover off everything. For anyone that hasn't heard of National Voices before, we're a coalition of health and social care charities. We've got over 200 members, and they really vary from large organisations like Cancer Research, Macmillan, British Heart Foundations of the world, to community-specific organisations such as Caribbean African Health Network, South Asian Health Action, Outpatients, and also smaller rare conditions charities, or often very small one-man team charities as well. So at National Voices, we have engaged with Brace and Decide previously, and we've also been doing some work around diversity and participation in clinical research too. And as part of what we do, we can provide advice and expertise on how to involve people with lived experience and really make sure that people with lived experience are brought in from the very beginning, helping with the design of research, but also materials, taking part in the actual research, the interviews. We can assist with that, and then also helping analyse findings and making sure we really maximise the outputs there. Some of our work that we've done with Brace and Decide have also included sitting on steering groups, supporting the PPI groups and PPI leads to really make the most of their engagement with people, and also helping with development of equality, diversity, inclusion plans, and also being able to comment and feedback on any material. So most recently we've done some work at National Voices looking particularly at patient information leaflets that are provided to people before they take part, and often they can be quite complex, quite difficult to understand, and be quite off-putting, especially if someone's limited on time or has caring responsibilities and the such. So we've looked at how we can maximise the use of patient information leaflets, but also make them accessible and inclusive. And we've got some work coming out next week around working with diverse communities and encouraging participation in research as well, particularly from a health inequalities focus. I think it's so important to engage people with lived experience from diverse communities. So at National Voices, over the past couple of years, we've really developed our lived experience function, and we've built up a team of lived experience partners who have been trained and coached to really be critical thinking partners with senior system leaders, with researchers, and our experts by experience. As part of their work, they obviously participate in all our policy work at National Voices, but they're also able to partner up with NHS England, the department, ICSs, and bring that lived experience to the decision-making tables, to the forefront, and ensure that there is diversity and strategic co-production taking place. So working with people with lived experience, I acknowledge that we're talking about rapid evaluation. The key thing that we've all said is time. It takes time to build relationships with communities. It takes time to build up a community of partners. But I think it's so important to mention that it's an investment. It seems like it will take a lot of time and resourcing now, but actually once you build up your community and you build those relationships, it's far easier to say, oh, we've got this work, would you like to participate, and have greater engagement. And in doing that, we really ensure that people, we really ensure that research outputs reflect the needs of the community and everyone. So often I think, and I'm sure at this point we've all heard the analogy around the baby and the babymobile. So the baby's in the crib and someone's obviously come out with this excellent babymobile that you hang on top that looks great. But actually for the baby that's laying underneath and looking up, you only see the bellies and the feet of the animals. Whereas from the outside looking in, it's all very aesthetically pleasing and colourful and seems exciting. So engaging people with lived experience from the beginning and making sure that you're really co-producing the research, the materials and the outputs ensures that it has the biggest impact overall for people's experience of health and care. One of the benefits as well around engaging people with lived experience is actually building trust in communities. I think particularly after the COVID-19 pandemic, we've seen a sort of a great fall in trust and confidence, particularly around minority ethnic groups, inclusion health groups, and communities experiencing inequalities, and actually engaging people in research and making them feel empowered to take control and feel like this is something that's going to improve my experience of care can be really beneficial in the long term. It can be difficult to find diverse representation, as we've heard from our work with Brace and Decide, but what I will go on to speak about is the role of the VCSE in this, and actually there are ways to overcome this too. So how do we widen involvement in research? VCSE partners are excellent partners in this because not only do they often have policy functions of their own, they're aware of insights and research and data that they've collected themselves, but they also have quite wide lived experience partnership networks too. So oftentimes VCSE partners will hold trusted relationships within communities that you can then go and reach as well, and really help you build out into minority ethnic groups, inclusion health groups, people experiencing homelessness, and the community groups that we often call hard to reach. And one thing that's really stuck with me through our work with lived experience partners is that these communities aren't hard to reach, they're easy to ignore because often they don't feel like they have the voice or the ability to participate in research like this. But actually it's just a matter of going out, making sure you're speaking to the right people, community champions, faith leaders, VCSE orgs and the like. As part of working with lived experience partners, one of the things that we advocate for is acknowledging and valuing their time and their participation in the research too. So ensuring there is budget for VCSE partners to support your work, but also reimbursing people for the time they've taken to participate in research, and being aware of alternative needs such as like having to arrange alternative care for people that are carers, being able to sort of cover the cost of transport and such so people can actually get to where you're meeting and things like that. It's also, through our work with Brace and Decide, we've also acknowledged the need to be flexible. So oftentimes we can come to the table with an idea of, this is the research, this is what we need, and this is what we want out of it. But actually having open and broad conversations with communities and say, what do you need? What would make the biggest difference to your experiences of care? And how can we help you? and starting the conversation in a far more broad and open way can actually have a greater input, because it widens the perspective and there may be things that you haven't necessarily considered before. I always say, we can have the most tech-savvy, innovative solutions, but if it doesn't work for the people that are experiencing the care and services, there's really no value in it. So really bringing people to the forefront. And at National Voices, we can, signpost you with our members, with community groups. So please do get in touch and say hello after the panel. I realise that I'm running slightly over time, so I think I'll leave it there. But if you do have any questions, please feel free to give me a shout.